Hello everyone and welcome to this presentation. I'm Lorna Willis and I work in a partnership between Cancer Research UK and the National Cancer Registration and Analysis Service, which is part of NHS England. I'll be presenting findings from a project which looked at the characteristics and drivers of patients waiting over 104 days from urgent suspected cancer referral to first cancer treatment. So NHS England has several standards for times within which patients should be seen at various stages along the cancer treatment and cancer diagnosis and treatment pathway. The most encompassing of these is the 62-day pathway, which is the time from urgent suspected cancer referral to patient starting treatment. The target for this is that 85% of patients should be seen within 62 days, but this 85% target has not been met since December 2015, and the proportion of patients starting treatment after 104 days has been increasing since before the pandemic. So 104 days is a sort of subsequent, is the longest time period that is routinely recorded in the sort of the routine releases of the 62-day monitoring data. And then 104 days is the point at which there should be a clinical review as to whether a patient has suffered potential harm from these long waits. And so it's a really key sort of measure for how patient experience and potential patient outcomes are being impacted. So we can see from this graph here, this breaks the percentage treated after 104 days down by specific sites. We can see that certain sites, there's a lot of variation by site, with certain sites including breast and skin, which are down the bottom of the graph, still having relatively low proportions of patients receiving first treatment after longer than 104 days. And then other sites, so lower GI and also urological are very high. So we can see that all sites have been have had this proportion increasing over time. So it's methodologically complex to determine the impact of delays on patient outcomes. But modelling studies have suggested that delays of even a few weeks could impact cancer mortality, and there are also patient experience implications of these long delays. To explore the potential impact and the potential reasons for this increase further, conducted discussions with clinicians which highlighted the multifactorial nature of drivers of increases in the number of long waiters, but the pressure on diagnostic services was frequently reported. However, the routine data that gets released doesn't provide the sort of demographic characteristics of patients, and so the potential kind of inequality impact of these patients waiting longer than 104 days aren't routinely available, and also neither are the reasons behind these delays to treatment. So this is what we were looking at addressing with this project. So in order to do this, we extracted data for all records for patients starting treatment following an urgent suspected cancer referral in 2017-2018, which we took as our baseline as the point before which the increase in the proportion of patients waiting over 104 days to start treatment began. And then we also looked at 2020, 2021, 2021, 2022, and the first half of 2022, 2023. This was just based on the data, the most recent data available at the time of extraction. And we took this from the cancer waiting times treatment data set. From this, we characterised the patients who were starting treatment after 104 days by cancer type, age, deprivation, and gender. We produced logistic regression models to identify the predictors of waiting over 104 days, controlling for the trust of decision to treat. And we also looked at reasons for the delay and the time that the patients spend in each part of the cancer pathway. To further also get a bit more detail about these patients, we also conducted a feasibility study that linked the cancer waiting times dataset to the rapid cancer registration dataset. This dataset is attempting to produce more real-time data compared to the gold standard registration data. So it has certain sort of reliability and completeness issues, but is far more up to date. So allowed us to include stage, diagnosis, ethnicity, and comorbidity in the analysis for these patients far earlier than would have been possible with the gold standard registration data. This did also necessitate a alteration of our base year to 2018-2019, just because the rapid cancer registration data only is only available from that year. So now on to our results. So when we were looking at the characteristics of the cohort of patients who are waiting over 104 days, this is mostly patients with urological, so that's 34% of the cohort, or lower GI cancers. And we found that the proportions have significantly changed between 2017, 2018 and the subsequent years, with an increase in proportion with lower GI, breast and skin cancer, and reduction in the proportion with lung, upper GI and urological cancer. We found that the majority of the cohort were of male gender, reflected by the cancers that are most represented in this cohort. But this did decrease with subsequent years, and again, the case mix of the cancer sites essentially explains this. We found that the most common age group was 70 to 79, and then the 19 to 49 age group was the least common, as we could perhaps expect from the cancer case distribution. But we did find that there was significant variation in these proportions by year, with increases in the proportion in the 70 to 79 and 80 plus age group, and a reduction in those in the 60 to 69 age group. Found that each deprivation quintile represented around 20% of the cohort, and these proportions remained similar between 2017, 2018 and the subsequent years. When we then linked to the rapid cancer registration data set, this represents a slightly different cohort now, so we have our 2018-2019 base year, and we also are only including patients where there was a unique linkage possible between the rapid cancer registration data set and the cancer waiting times data set. But we found that stages 1 and 3 were the most common stage, 34 and 30%, while stage 4 was a small proportion. So this is at 11%, and this was of where stage was known. So also, even though this stage 4 is still a small proportion, there's still a substantial number of patients who are at stage 4 who are waiting longer than 104 days to start treatment. And we found that the proportions by stage didn't vary across the years. Found that 88% of the patients were of white ethnicity, with 5% of Asian ethnicity and 4% of Black ethnicity. And when we were just looking where this is known, the proportions changed over time, with increased proportions of patients of Asian or Black ethnicity and with a mixed ethnic background in subsequent years compared to the baseline year of 2018-2019 in this case. The majority of the cohort had a comorbidity score of 0, around 80%, with 11% having 1 comorbidity and only 5% 2 or 3 plus respectively. This did vary significantly between the baseline year and subsequent years, with a slight reduction in the proportion with 0 comorbidity. So these results sort of give us a picture of the overall cohort of those waiting longer than 104 days to start treatment, but it obviously is impacted by the proportions in each of those categories. So the age groups, the proportion that the numbers in all the age groups are going to be larger, so we would expect them to take up a larger proportion of the long-waited cohort. So we've also looked at the percentage of all patients who have an urgent suspected cancer referral, who were treated after 104 days. So here you can see by site. So you can see that for all sites, there has been an increase over time, with 2017, 2018 relatively low, and then increases continuing in subsequent years, even post the kind of 2020 pre-pandemic period essentially. But we can see that there is still a vast amount of variety by site, with breast remaining relatively low and lower GI up at around 20% of patients waiting longer than 104 days in those first 2 quarters of 2022-2023. We've also looked at this broken down by deprivation quintile, and we can see that there is a strong deprivation gradient, with those in the most deprived quintile the most likely to having the higher percentage of patients who are waiting over 104 days to begin treatment. And again, this is consistent across all the years, but all of the quintiles have seen a continual increase. We also have results by stage, and we can see for the stage, again, all the stages have seen an increase. However, it looks like the stage 3 has the highest percentage of patients treated at over 104 days, and there is also a lot of variation in this by site. So some sites have a continual increase of stage, whereas others have stage 4 being far lower than other stages. So next, we're going to talk about treatment intervals and potential reasons for delay. So there are various targets, and they all mostly start at the point of referral to a specialist, and then end either at the first specialist visit, the point of cancer being ruled out, the point of first treatment, that's for the whole pathway, and then there's also a treatment-specific target, which is treatment within 31 days of decision to treat. Here we have a breakdown of the reasons for delay from referral to treatment, so that's across the whole pathway, and we can see that the most common reason is healthcare provider initiated delay. So this is mostly things to do with elective or inpatient capacity being inadequate, and that the proportion with a healthcare provider initiated delay has increased over time. A further way to look at the kind of potential place in the pathway where delay is occurring is to look at the median time frames. So here we have a graph that's saying the median time from in each of those sort of pathways seen across the various different treatment intervals, and the median interquartile range. And we can see that the time from decision to treat the treatment is very short, so has very short median, whereas the time from referral to decision to treat is very long and is relatively similar to the full referral to treatment. So this is just for the cohort waiting over 104 days. And for these patients, it seems that the time in referral to decision to treatment is constituting a large part of the pathway and potentially the reason for delay. And we have also conducted regressions, and we did this for each individual site based on the differences in pathways for each individual site. And we found, yes, that there were certain characteristics that were most associated with being long waiters. So for lower GI, patients who have rectal cancer are around 1.2 times more likely to be a long waiter compared to those with colon cancer. And there's also a strong deprivation gradient with patients living in the most deprived areas having the highest likelihood of being a long waiter. And we also find results for stage, so there's a lower likelihood of being a long waiter, and it's around half as likely for stage 4 compared to stage 1. Okay, so in summary, we found there would be changes in the characteristics of those waiting over 104 days over time, although increases in the percentage of long waiters have impacted all groups. Our findings indicate that the proportion of delays initiated by the healthcare provider have increased from 2017 to 2018, and the cancer pathway intervals indicate that referral to decision to treat is likely to be the main point of delay. The percentage in findings vary by cancer site, as would be expected from the different diagnostic and treatment pathways and capacity. And this was strongly highlighted in clinician feedback, and also the value of site-specific descriptive data, whereas from the analytical perspective, we were very focused on the regression models. They found it still very powerful to just have the sort of the percentages that were waiting over 104 days. The use of the rapid cancer registration data set enabled timely, more detailed characterization of the cohort, but there are limitations in terms of data completeness and reliability. And we also have some potential feature analysis, including variation in reasons for delay by characteristics and the impact of transferring between trusts. Finally, just to acknowledge all of the patients whose data enabled this project, and yeah, many thanks to colleagues within NHS and the REK. And thank you very much for listening.
Thank you very much, Lorna. And again, probably time for one, maybe two very quick questions.
Is there any kind of hypothesis on why saying that?
Yeah, so there's definitely lots of very interesting things around stage, and I think in order to delve into the reasons for that, I think it's very important to focus on the site-specific data, which I think was a really key thing that kind of came through in the feedback that we're having around some of the wider stuff. While potentially useful from the service perspective, it's kind of obscuring quite a lot of the details. There's some sites where I guess potentially patients are very at an early stage are far less likely to present with very acute symptoms, where they're more likely to be in the long waiters category, and then other sites where either it's kind of easily sort of more easy to pick up at an early stage, where we do kind of see patients at stage 4 who are potentially waiting kind of longer or having other kind of other sort of comorbidity kind of issues and things like that, who those patients do kind of see longer waiters as well. So yeah, the by site kind of picking that apart is definitely really interesting and key for sort of understanding some of the slight kind of counterintuitive results in some ways.